This podcast is sponsored by Jabra Enhance.
How are your hearing aids sounding now?
A little tinny.
Okay, 2 seconds.
With Jabra Enhance Select's premium package, better hearing doesn't happen in a doctor's office. It happens at home, all done remotely from initial testing to adjustments.
How are they sounding now?
Fantastic.
You get the same advanced hearing aid technology and professional support you expect from a clinic at a fraction of the cost. And if you have any issues, we'll make adjustments 7 days a week, no charge.
Oh, you people are wonderful.
Our premium package includes hearing aids, 3 years of follow-up care, plus a 3-year warranty with loss and damage coverage, and a 100-day money-back guarantee.
I hear better than I ever thought possible.
And now, for a limited time, save $100 when you order Jabra Enhance Select Hearing Aids with promo code PODCAST. Go to JABRAenhance.com, enter promo code PODCAST to save. JabraEnhance.com, code PODCAST.
For eligible individuals 18 and older in 50 United States and Washington, D.C. with mild to moderate hearing loss only. Audiology team may not be able to program hearing aids for some types of hearing loss. See website for details and important safety information.
Judy was boring.
Hello.
Then Judy discovered ChumbaCasino.com.
It's my little escape.
Now Judy's the life of the party.
Oh, baby, mama's bringing home the bacon.
Whoa, take it easy, Judy. The Chumba life is for everybody. So go to ChumbaCasino.com and play over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com.
No purchase necessary. Void where prohibited by law. 18 plus terms and conditions apply. See website for details.
Welcome to Handle with Care, Breast Cancer and Beyond, a safe place where both women and men can come and listen to real people talk about their breast cancer experience and the effects that follow well into survivorship. Hosted by Carrie Madrid, a Stage 3 breast cancer survivor and founder of the CARE Project. It's time to Handle with Care.
Hey everyone, welcome back to Handle with Care, Breast Cancer and Beyond. My name is Chris Donovan. I am the producer and co-host here with Carrie Madrid of the Care Project Inc.org. Please go to that website and check out everything that she's involved with, like her book and everything, including more things about this podcast. Okay, selfish plug out of the way. Today we have a great show for you. Now today we're joined with Dr. C and Terry. Now we call them that because both their last names are kind of hard to say. But beside that, Dr. C is an amazing surgeon and Terry is one of the happiest patients that he's ever had. And they're going to talk all about their foundation, their missions, and their journey being touched by breast cancer and other types of cancer. So please enjoy this episode with Dr. C, Terry, and Carrie. Hey, that rhymed. All right, enjoy.
Hey everybody, welcome back to another episode of Handle with Care. Today's episode is all about breast reconstruction and more specifically the DIEP flap procedure, which is what I had done in 2013. Many people just don't realize that there are so many different types and forms of reconstruction beyond implants. And anytime you tell somebody that you have breast cancer, they immediately go, oh, well, at least you're going to get new boobs. You're going to get great implants. And that's not always the case. And truthfully, some of us don't want implants. So we're going to explore what exactly DIEP flap is and what amazing results you can obtain only if you've got an excellent surgeon and if you're a good candidate for it. So I had the pleasure of meeting Dr. C a couple of years ago at the Male Breast Cancer Coalition's annual conference in Florida. He may not know this, but I was so excited to meet him. Like I was like a fangirl because I had been watching him on social media and following the practice, PRMA, which is out of San Antonio. And I just knew that he was the best of the best. State of the art, procedures I hadn't even heard of, and yet here I live in Cancerland. So I got to talk with him personally over, I don't know, the cocktail hour or something. And what I was so impressed by is there was a room full of people, and while we chatted and I probably told him way too much information about my experience and all my complication, he was so intently listening to me, and yet I wasn't his patient. And then I read all the reviews about his actual patients just screaming about his compassion and empathy for them. And so I knew I had to talk to this guy. Plus, he's like an amazing surgeon. So he's board certified plastic surgeon and microsurgeon specializing in state-of-the-art breast reconstruction. He's also the creator of the Breast Advocate app, which we're going to talk about, which provides anyone with a breast cancer diagnosis or anyone at risk of developing breast cancer a much-needed voice in their decision-making. And as a patient, I know just how important that is. So you can read his full bio on his website, which we will put in the show notes, because if I keep talking about his bio, we're going to be here for the whole hour. So I'm honored to welcome you, Dr. C. Thank you so much for your time.
Oh, thanks for having me. Who wrote that? Who wrote all that stuff?
You know what? Here's the thing. If you ever listen to my show, you know I don't write anything. I don't prepare anything. I don't like to do formal interviews. I like to wing it and have conversation like we're talking cocktails. But you have so much about you. I was like, I got to type this out. So that'll be the end of my reading. But after I talk about who else is joining us. So I wanted to make sure that we had one of Dr. C's patients and one of his biggest fans with us, a fellow cancer survivor who's actually a 2-time breast cancer champ, patient advocate, podcast host, and founder of the Deep Sea Foundation. Terry is with us. Hi, Terry.
Hi, Carrie. So nice to meet you and finally talk to you.
I know.
Did you say I was one of Dr. C's biggest fans? Was that in my bio?
I think I ad-libbed that.
I think so.
Well, okay, it's true.
He may have slipped me a 20 for that. I don't know. Anyways,
yeah, I could see that happening.
The reason I wanted to have Terry here is because I underwent my procedure in 2013 and I had major complications that actually were life-threatening. And I'm still not satisfied and I'm still not complete with surgery, but I kind of put a kibosh on any further revisions until I feel comfortable doing so. But Terry's had a great result. And so I want to talk, with Dr. C to both of us. He's seen pictures of my results, both the day before my mastectomy and then current day. So we're going to talk about that as well. But first, Dr. C, tell everybody in layman's terms, what exactly is DIEP flap?
So it uses your lower abdominal tissue, right? So skin and fat to recreate a new breast or both breasts, depending on your situation. Now, there are lots of different techniques that use the lower belly tissue, the lower abdomen. The tram flap was the initial procedure that was described many, many years ago. That takes your abdominal muscle. So sacrificing your abdominal muscle, your six-pack muscles, really can impact your core strength, and it can lead to bulging or a pooch and even a hernia. Thankfully, those risks are low, and most women who have a tram flap, if they're having one breast reconstructed and they get to save the other abdominal muscle, the other sit-up muscle, a tram flap is usually very well tolerated. So I don't want people to think that if your surgeon only performs a tram flap, then, run. That's not what I'm saying at all. Most people tolerate that procedure well. It's a good procedure. The issue with the tram flap really, and taking that muscle, sacrificing the sit-up muscle, the issue really is much more pronounced when you're reconstructing both breasts, because then you can get a big hit to the belly, to the core, your trunk muscles. You have to use mesh to close things up. The risk of hernia is higher. So really, when you're doing a bilateral breast reconstruction and you're reconstructing both breasts, a traditional tram flap really is not that great an option anymore, considering how things have evolved. And over time, that procedure was modified to a muscle sparing procedure to try and save as much muscle as possible. And then the DIEP flap is the evolution of that. The DIEP flap takes no muscle. So that really preserves all your internal musculature, your sit-up muscles. From an activity standpoint, the vast majority of people can get back to their activities. The risk of bulging or a hernia is much, much, much lower. Hernia is less than 1%. A bulge is about 3%. So much, much lower than with a tram flap. And then there's another procedure that's even less invasive than a DIEP flap, and that's the SIEA flap, and that's just dependent on the blood vessels that feed the tissue. The tram flap, DIEP flap, and SIEA flap, if you looked at a patient that had each of those procedures, the external scarring is the same. So it's a little scar around the belly button and a long scar, usually from hip to hip. So from the outside, you really can't tell what procedure a patient has had when they've had their lower belly used to reconstruct their breasts. So what we're talking about tonight really has become the gold standard. The DIEP flap is the gold standard in breast reconstruction today. We can talk about, I can talk all night about the benefits of using your own tissue over implants.
That's what I was just going to ask you about. Yeah. Everyone asked me that. So you don't have implants? And I'm like, no, to be honest, I just didn't want anything else foreign in my body.
Well, and that's a very common feeling, especially these days with the negative press with implants. So again, I don't want people to feel like we're bashing implants because, we do implants. Implants can be a great option for some women. You can get a phenomenal result with implants, right? And so just to be clear, if you want implants, that's okay.
Absolutely.
You've still got to do your homework. You've still got to do your research, and you've still got to look at very, very specific things to maximize the chances of a good outcome, right? You got to get the right team for one, because, a big take-home message I want people to get from this conversation is that your plastic surgeon can only use what's left behind by your breast surgeon. So don't think that you can go to any breast surgeon, and as long as your plastic surgeon is world renowned, you're going to get a phenomenal result and look like you've had a mummy makeover. Because that world renowned surgeon, he or she can only use the tissues that have been left behind. And so the quality of the mastectomy is make or break. So you've got to pick your team. Pick breast surgeons that work with plastic surgeons all the time, preferably the same one, so that there's an understanding. That really goes a long way to maximizing your outcome.
Absolutely. I wish I knew that when I was going through mine. I just, you don't know what you don't know. So that's why we're doing this.
Exactly right. And so, going back to your previous question about, the benefits of tissue in general, tissue, it's you, it comes from you, you can't reject it. It's warm, it's soft, it has a better potential to regain feeling over time. We're doing a procedure called TrueSense that involves nerve reconstruction. We've been doing nerve reconstruction for many, many years now to restore as much feeling as possible to the reconstructed breast, because the mastectomy very, very frequently and usually cuts the nerves that supply feeling to the breast skin and the nipple and the areola. So again, going back to the breast surgeon, plastic surgeon combination, the best situation you can be in if you're having a mastectomy, if you're in that unfortunate situation, is to have a breast surgeon that even looks out for the nerves and tries to preserve the nerves. And this is a conversation that's only just being had now. And so if you come and see me, we see patients all the time that want nerve sparing techniques and nerve reconstruction. I tell them people travel for it. But ironically, the best situation that they can be in is not to even need a nerve reconstruction, because the nerves appear to be intact after the high quality mastectomy, right? So that's what the team is crucial. I can't overstate that enough.
Yeah, that's so true.
And the other thing is, people say, "Oh my gosh, I've got cancer. I don't have time to find a team, do research." That's nonsense. Okay. Yes, anyone with a cancer diagnosis wants the tumor out yesterday. When can you get me in? And some surgeons, unfortunately, give the impression that it's an emergency. It's not. Okay. By the time a tumor is picked up and diagnosed, I hate to break it to you, but you've had it for a while.
Yes.
An extra couple of weeks makes no difference in terms of your prognosis. It really does not make any difference. So you do have a little bit of time to do your research and ask some questions. You don't need surgery the next day after your biopsy.
So let me tell you this. So when I had my biopsies and went in and saw the surgeon who was the chief of surgery at that time, and he said, you've got 2 tumors. You've got one very large one that's infiltrating ductal, and you've got one that's DCIS, much smaller. Very different areas, 3 o'clock, 6 o'clock. And you need to have a mastectomy right away. And I said, okay, I'm okay with that. Can we just take both? And he said, and I think that was just my knee jerk, in shock reaction. And he said, well, I can, but I'm just the general surgeon, if you will. And I already had a reduction 9 years prior. So I had a set of scars he had to work around. So he said to me, I'm not going to make it real pretty. I'm going to go in there and do my job and get the cancer out. And I would suggest you just have a single mastectomy now. Let me get the cancer out. And then when you see the plastic surgeon, he'll make it all pretty. He can take the other one at that time. I didn't know what I didn't know. And I went, okay. I also said, well, I was booster president at the local high school for the basketball program. And I was like, we're in finals. We're going to state for the first time. Can this wait like a month? He was like, oh no, can't wait a month. He was like, you need to have this. By the time I left that office, I was scheduled for 11 days later.
Yeah. And, it's, do we want people to wait a month? No. Do we want people to go on their, round the world trip and
right.
put things off for 3 months? No.
Yeah.
But what I'm saying is, you had a few days and the demographics matter, geography matters, access is an issue for a lot of people. We're going to mention a lot of things that, on this chat that unfortunately isn't realistic for some people, right? So I'm very sensitive to that too. And in that regard, you've got to unfortunately do what you've got to do to get through the situation and take care of your cancer, right? It's life before breast. Okay. I mean, that's just the way it is. Right. So, but many, many women, and in the US, I would say most women, are generally going to have other options they want to consider if they look into things.
Right.
So it's a very emotional time. You don't know where to turn, but that's why the three of us are, and other patient advocates are, doing what we're doing is because we're trying to get this message out that, you got just take a deep breath,
Right. So important because, here's the thing. I've worked for the same medical company for 22 years. I have a really good medical, dental, vision, all that. I have an HMO. So to me, it's great because I don't have to worry about a bunch of out of pocket because I have been a divorced single mom for many years. And so, I, for many, many years lived check to check, but I didn't mind because I worked from home. So that meant I was a stay-at-home mom, but I had the benefit of a paycheck and all these fantastic benefits, right? All my kids had braces, despite us being a poor single mom household. Everybody had braces, everybody got training, driver's training. But I really thought, and I still believe I have pretty decent healthcare coverage. But because I'm in an HMO, I'm pretty much stuck in this program of, okay, so you have breast cancer. Now you're going to see this oncologist and you're going to have this surgeon and you're going to go see this plastic surgeon. And ironically, the plastic surgeon that did my reduction 9 years prior to ended up being my plastic surgeon for reconstruction. So I felt very comfortable with him. I thought, oh, fantastic. He kind of knows me sort of, and I felt like I was in good hands, but you've seen my result. I mean, we could go on for days. Who are the best candidates for this type of reconstruction?
With the Lucky Land Slots, you can get lucky just about anywhere.
This is your captain speaking. We've got clear runway and the weather's fine, but we're just going to circle up here a while and get lucky. No, nothing like that. It's just these cash prizes add up quick. So I suggest you sit back, keep your tray table upright, and start getting lucky.
Play for free at LuckyLandSlots.com. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.
Okay, round two. Name something that's not boring.
A laundry? Ooh, a book club. Computer solitaire, huh?
Ah, sorry. We were looking for Chumba Casino. That's right. ChumbaCasino.com has over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.
A lot of people. Really, it's who isn't a candidate. Really,
Okay.
It's probably easier. Women who have had women who don't want a tissue reconstruction, number one, women who want implants. If you've had a lot of abdominal surgery, that makes it harder. Now, we see people all the time that, just because they've had a couple of C-sections, or some liposuction or something, they're told that they're not a candidate. That's not necessarily the case.
I never thought about that. C-section.
Yeah,
Sounds
no, I mean, it's very,
C-section.
very common. I mean, these days, a lot of women have had, have scars on their belly. Just because you've got a scar on your belly from previous surgery, it doesn't automatically disqualify you, which is what a lot of women are told. And you've got to realize, and I think you've picked up on this too with your experience, right? And certainly with the advocacy that you're both doing. And thank you both very much for doing that, by the way. It's a really big deal. I think you both realize now that many women are told they're not candidates for things that they are indeed candidates for. And sometimes it's because the surgeon doesn't offer those techniques.
Mm-hmm.
I mean, it's this big elephant in the room. People don't talk about it, but I'm sorry, if you don't do it, you're not going to offer it. And it's not out of malice, but, as humans, what we do is we double down on things that we're most comfortable with, things that we're familiar with, that we understand, techniques that in our hands reproduce good results day in, day out. And the older you get, and I'm not ageist, but this magnifies over time because, you just get more set in your ways and you don't want to try the latest, greatest. And, tram flap is great, or, oh, you're not a candidate for tissue, says the surgeon who only does implants, right?
Right.
There's always, there's a lot of that, unfortunately. We see people all the time at PRMA who have been declined deep flap surgery elsewhere because they're told they're not candidates. And it's strictly not true. And sometimes we're scratching our heads is, why on earth is this person not a candidate? Sometimes you get it. They've got a midline scar, they've had a C-section, they've had an appendectomy, and okay, I can see how that would be scary if you don't do the procedure day in, day out. But some women, they've got no business being told that they're not a candidate,
That must be so frustrating for you.
Well, it's more frustrating for them.
Oh, yeah.
So, I've gotten frustrated over the years over many things, but I just remember that I'm not in their shoes. And by definition, there's no way I can be as frustrated as they are, right? So that keeps me grounded.
Yeah.
But also, getting mad doesn't really help me.
Yeah. We need you to stay calm, Dr. C. Stay calm.
It doesn't change anything. So it is what it is.
Yeah.
And the other thing is you don't have to be heavy to be a candidate. So even thinner ladies can have deep flap surgery if they've got, the tissue that they have, if it's in the right distribution. It's not just how much tissue you have. It's do you have enough and do you have it in the right place, right? And so, thinner ladies, it's a little bit harder to keep the scar low.
Mm-hmm.
Sometimes thinner ladies sometimes can't get the final size that they may prefer. There are often some compromises, right? But I mean, we do deep flaps on ladies with a BMI of 19, 20.
Wow. I never knew that. That's great information.
So I mean, it depends on, if you don't have very much in your belly, or if you don't particularly want to be very large, and if you're more kind of athletic and you've got a smaller cup size to begin with, and you're just looking to recreate that, and you've got a little bit of tissue, you're a mom, you've had a couple of kids, you may work out, but you've got the stubborn little area that pisses you off, but it's not, not that much, but it may still be enough to recreate a smaller breast if it suits your frame, right? So
that's really good information.
Yeah, many women are candidates. We see a ton of women who are turned down for reasons that really shouldn't be turned down if that's what they want.
Yeah. So let's talk about complications.
Yeah.
So with every surgery, there's risk of all kinds of complications. You've seen mine, where my radiated side, the tissue transplanted, it's split open underneath.
Mm-hmm.
And I didn't feel it because I have no feeling in my chest wall. Mm-hmm. And so as I was home recovering from my surgery, in my recliner, I was there with two teenagers. The older one not interested at all and doing her own thing, and the younger one in junior high, checking on me, and she's like, "Mom, you've been sleeping nonstop. What's going on? And you haven't drank any water. And let me give you some water. Mom, you haven't eaten in a day." And I was out of it. I didn't even know. Thankfully, I had a post-op appointment the next day, and one of my dear friends was off work, so he was coming to pick me up and take me. And when he scooped me up and took me in, and I don't even remember it, I passed out in his truck. We drove 20 minutes to the hospital. When I checked in, my fever was 106.5. My plastic surgeon said, take her immediately to ER downstairs. And I was like, what's happening? I was septic.
Mm-hmm.
So I had a staph infection from this open wound. How often does that happen? And do you suspect that happened because it was a radiated side, or did I do something to cause that?
No, it's really rare. It's rarely a patient's fault. Okay. I mean, stuff happens. So thankfully, that kind of complication is really rare, to get to the point where you're admitted with a temperature of 106 and because you're septic, that is thankfully very rare. I'm sorry that happened to you.
It was something else.
Very rare. Radiation increases your risk of complications, period. It just does.
For almost all reconstruction, right?
Absolutely, in one way or another.
Right.
Anyone who's had radiation is always at higher risk of a complication compared to someone who has not had radiation. That's just the way it goes. The risks from radiation are much, much worse with implants. So if you've had a mastectomy followed by radiation, trying to put an expander under that skin to recreate a breast mound, as it's called, and stretching that radiated skin, it can be very, very tough in many women. The radiation increases the fibrosis, the scarring. It makes tissues much more firm and less stretchy, less elastic. And so even if you can stretch it, it can be very, very uncomfortable. And even if you can get an implant to work in that delayed reconstruction setting, it ends up being this hard rock on your chest, not this nice, pliable, soft breast, right? So especially in the setting of previous radiation, a tissue reconstruction for sure is the gold standard, right?
Yeah.
Now, unfortunately, you can still have major healing issues where the radiated skin meets the healthy tissue that's been transplanted with your flap, right? So it doesn't mean you can't have a wound healing problem if you have tissue. It just means that and that's what happened with you, where it broke down. It was at the bottom of the breast, the heaviest point where your flap is attached to your chest, and it was attached, to radiated tissue, which it's very difficult to avoid doing that if the radiation, the field of radiation, as we call it, how extensive the radiation was, it's usually pretty wide, right?
Yeah,
so,
mine was very wide.
Right. And so by definition, your surgeon, he couldn't avoid attaching it and sewing it to radiated tissue because the radiation field was so wide, right? So by definition, you had a higher risk of wound healing problems. And where your wound developed was actually at the highest stressed point because it was the heaviest, it was taking the weight of your tissue.
Right.
And then it's underneath your breast. You can't see it. You're out of it after surgery, gets infected.
And I was in the hospital for like 8 days.
Yeah.
I wasn't even up and walking until day 7.
Yeah. Well,
I know. So let's talk to Terri. Let's talk to Terri for a minute, because I know she's going to have to drop off soon. She's got a hot date.
Oh, yeah.
Terri, talk to me a little bit about your experience. Like, how did you meet Dr. C? How'd you find him? And what made you choose this type of reconstruction?
Well, it was my second diagnosis, Carrie, that led me to, deciding to do reconstruction. And what's really strange, I've talked to a few ladies about this in the last couple of weeks. When I was diagnosed the second time, and I walked into my breast surgeon, who was in Arizona, where we lived at the time, I was not even prepared to go in to talk to her about reconstruction. I was going in there to find out if she was going to take my breast off. And in my mind, I was going to live flat the rest of my life. I was going to live without breast.
You had lumpectomy the first diagnosis?
Correct. The first diagnosis in 2002, I had 2 lumpectomies, chemotherapy, 6 weeks of daily radiation, which caused a lot of that fibrosis that Dr. C was just talking about in my left breast. But in 2014, I had a recurrence and a new primary in my right breast. So I felt pretty certain that I was going to lose my breast. But the day I went in to talk to my breast surgeon about what my next steps were for my best prognosis, I really and truly thought, she's going to tell me I'm going to have a double mastectomy and I'll live flat the rest of my life, because I didn't know anything about breast reconstruction. Well, thankfully, she was very well trained, very well informed, very well connected, and totally believed in the shared decision making model that Dr. C and I are so passionate talking about. And she sat there and told me, she said, Terry, I am going to have to do a double mastectomy on you, but you can reconstruct your breast. And I just sat up in my chair and I'm like, wow, wasn't prepared to come in to talk about this. And she gave me all my options. She told me about implants, and she gave me all the literature that she had on implants, on alloderm, on the various types of implants, saline, and silicone. And then she talked about deep flap. She goes, well, there's a gold standard in breast reconstruction right now, and it's called deep flap, and it's using your own tissue. And I tell you, Carrie, after she told me that, it's like mufflers went on. Yeah. Everything else went out the door for me, because I'm like you, I'm a purist, and I didn't want anything foreign in my body. Well, my breast surgeon, this was in April, mid-April by the time I saw her. And it was my second diagnosis. Dr. C was talking about your team and the timing of your reconstruction, the timing of any surgery that you have. What I tell patients now is ask your breast surgeon, ask your oncologist, how long can I wait to have my mastectomy for my best safety, for my best long-term outcomes? I didn't do that. So here's what happened to me. She said, well, I can get you on the schedule. However, after May 15th, I'm going to be gone for a month. So this is April. I'm a patient who's already been my second diagnosis. I'm like, she's going to be gone a month. That puts me into mid-June for her to even do my mastectomy. I'm like, take them off. Take them off. Can't mentally wait that long. Maybe I could have, maybe I couldn't, but I didn't ask the question at the time. So I tell women now, I encourage them to ask that question. So had my double mastectomy in mid-May, and we had already talked about deep flap. I had decided that's what I'm doing. I'm going to do deep flap after my mastectomy. I'll look for my reconstruction surgeon later. Access to care is a huge issue, like Dr. C said. There was a surgeon in my town who was very well trained. For reasons of my own choosing, I did not go to him. A lot of it was personal choice and the fact that he didn't work with two surgeons. There were some other reasons too. I don't really care to go into at this point. It was just more attitude than anything. And that counts for a lot when you're having a discussion with a surgeon. Mm-hmm. So I told her, I said, and I love my breast surgeon. I think she's a wonderful, skilled person. I told her, I said, well, while I'm healing from my mastectomy, I'll look for a reconstructive surgeon. And it was a really difficult year for my husband and I both, because he had been overseas. He came home. He lost his mother shortly after that. We just had, and then I had some tests that just really went south on me, and the results, and it was kind of a year from hell for us. But I took the time to look for a reconstructive surgeon, and I looked all over the country. Because I knew that it wasn't going to happen in Arizona, where I was living at the time. So I literally looked all over the country. And for women that are looking all over the country, and I even tell them this, go somewhere where you either have support in the town that you're going to go to, or if you don't, ask your friends, ask your family, ask that tribe who surrounds you and wants to help you through your breast cancer Reconstruction, ask that tribe if they can travel to help you out, because you're going to need 2 weeks.
Lucky Land Casino, asking people, what's the weirdest place you've gotten lucky?
Lucky? In line at the deli, I guess?
Aha, in my dentist's office. More than once, actually.
Do I have to say?
Yes, you do.
In the car before my kids' PTA meeting.
Really?
Yes.
Excuse me, what's the weirdest place you've gotten lucky?
I never win and tell.
Well, there you have it. You can get lucky anywhere, playing at LuckyLandSlots.com. Play for free right now. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18 plus. Terms and conditions apply. See website for details.
Can you have zero interest in something and still really want it? Your wallet would say yes. And with Simply Zero from South Carolina Federal Credit Union, you can transfer credit card balances and get 0% intro APR for 12 months. That's right, no interest all year. So you pay less and keep more. To learn more, visit scfederal.org/simplyzero. That's scfederal.org/simplyzero. Variable APR ranges from 11.74% to 17.99% thereafter. Limited time offer. Restrictions apply.
Give or take a couple of days when you have deep flap. So for me, all roads led to San Antonio. And the reason is because of their skill rate or their success rate. What that means, some women say, well, what's success rate mean? Does that mean they're easy to talk to? Or do they have a really cool British accent like Dr. C?
Yeah. Are they funny? Do they cuss a little bit?
Are they funny? What does success rate mean? Well, when you're talking about deep flap, what success rate means is how many, it's kind of a reverse of what I'm saying here. How many flap failures have they had? And so if a surgeon has very few flap failures, and trust me, they're all going to have flap failures. Everybody does. But you want a really high success rate. PRMA was 99% or more. I'm like, okay, check that box.
Yeah.
2 surgeons in the room for the deep flap. Check that box. That means less time under anesthetic for the patient. It is less wear and tear on the surgeon, right, Dr. C?
Yep.
How long was your surgery, Terry?
Mine was start to finish around 8 hours. But here's the thing. People talk about the length of their surgery. I went to the hospital early that morning. I got there like at 6:00. They didn't even wheel me back. There's prep and everything. Mm-hmm. They didn't even wheel me back till 9. Well, you get into the OR, you get into the room, there's probably another hour or 30 minutes of prep. Then the doctors come in. So the actual time they were working on me, what would you say, Dr. C? Maybe 6 hours?
Yeah,
total.
Yeah, really.
For me, because I'd already had my mastectomy, okay? But I know it varies from patient to patient. But I guess I caution patients when they hear things like, well, I had 18-hour surgery. I had 15-hour surgery. Yeah, Carrie, you had long surgery for reasons that, are unfavorable. But if you go to a well-qualified surgeon, have 2 surgeons in the room, your OR time is going to be shortened. And so I guess I was, on the table maybe all of somewhere between 6 to 8 hours. Mm-hmm. But I did have my double mastectomy prior to that. So that couple of hours for the mastectomy was taken out. So the other reason that I went to them too is because they do nerve reconstruction. And I was left numb after my mastectomy. And so I wanted an opportunity at least to be able to regain sensation in my breast. And that in fact did happen because Dr. C performed a procedure called microneurography, which basically, along with the blood vessels that they transfer from the belly to the breast area to reconstruct the breast, they also look for a nerve in the tummy area. Then they look at those nerves that have been severed due to the mastectomy, and they reconstruct that nerve that they find in the belly area to one in that intercostal plane, they call it, the nerves that feed into the nipple areola area from both, the outside coming from your, let's see, we don't have visuals here. We're talking, nobody can see me, but coming from the armpit, side of your breast, feeding into the nipple areola, and then also from the medial part of the sternum, feeding into the nipple areola area. So I had the reconstruction done, and because I had radiation 12 years prior to my deep flap, Dr. C told me the morning of my surgery, he said, we're going to remove some of that scar tissue from your radiation, because even though I had gone to the gym and really stretched my arm out very frequently after my first 2 lumpectomies and radiation, I still had that tethering and that tightness under my breast. And, my claim to fame is I used to tell people I never laid on my left side before my deep flap. It was uncomfortable because I had all that, scarring from radiation. And after my deep flap, I lay on my left side all the time now. So
I'm real jealous right now.
Yeah. Did I answer your question? I got off on a tangent, but
no, you did. You did.
Yeah,
so
yeah.
Tell me, what I want to hear about is how, because I'm going to have you on another show because I want to talk about your foundation and go more in depth with your advocacy work. But tell me what your recovery was like. Like, how long were you in the hospital?
Terry's a little bit mad about that because we changed things after surgery. She's still a little bit, you're a little bit spicy when it comes to that.
I love that. I'm going to get a shirt made that says spicy. I like that.
Yeah.
Spicy.
My Rich, our oldest son, Dr. C, you've met him. His youngest daughter is spicy. I have a daughter that's spicy. So yeah, maybe spicy is a good term for it. So no, Carrie, what Dr. C's talking about. First of all, I was in hospital for 5 days, but there was a reason for that. I was an out-of-town patient, and to be honest with you, I could have been released on day 4. Dr. C knows my husband well, and he came into the room, and I said, you know what? I probably could go home today, but I don't think my husband's ready. Oh, he was so nervous about taking care of me. And my best friend was flying in to take care of me the next day. And I said, one more day. He says, all right, I'll give it to you. So in reality, I could have gone home on day 4. But let me tell you what the difference is and what Dr. C's talking about. There's a protocol that was put into place at PRMA. And now there are several, the larger health facilities, hospitals across the country are now using this protocol called ERAS, and it stands for Enhanced Recovery After Surgery. So what that does, without going into too many details, it reduces the use of narcotics. They carb load patients the night before surgery, the morning of surgery in most instances, so that what that does, and they use less fluids, less IV fluids in the OR, all of that, Carrie, translates into your body being able to get back to a normal state quicker. These patients are getting their catheters out, I don't know, the day after, right, Dr. C?
Yeah, that's right. Day
after, they're going home at day 2. I had my catheter in for
fathom
3.
going home on day 2. There's no way I could even. I couldn't even hardly breathe, let alone go home.
Things have changed a lot, though.
Well, the thing for me, I honestly didn't have much pain after my DEEP. I really didn't. That was not the issue for me. I was fortunate I didn't have nausea either. And but what I hated, because I'm spicy, it was so hard for me laying in that bed for 5 days.
Yeah.
And At day 2, I started walking the halls as much as I could. I was so tired of not eating food for 2 days. I'm like, if they bring me another bowl of hospital broth, I'm going to throw it in their face. I'm going to spicily throw it in their face. So when I went back and saw patients who had been using AirAss, they had their catheter out. They didn't have multiple bags. Remember those IV bags, Carrie, that we carried around the hall?
Yeah.
Multiple bags on there, including our catheter.
Right.
They had maybe one bag on their IV pole, no catheter, and they had real food on their table the next day. I'm like, what the hell? Why didn't I get that? So AirAss has been
incredible.
a game changer. Yes, it's been a game changer. And the use of less narcotics, because I had the patient-controlled pain, and it was, through my IV until Dr. C, came in about day 3, and he says, we're going to switch you to oral pain meds now. And I was, I couldn't hardly carry a conversation on.
Yeah.
So I don't want to know what I told him the morning he walked in after surgery and what I said to him, because I don't remember, and I don't want to know probably.
Yeah.
I was just zonked out on drugs, but yeah.
So your recovery was nice as could be.
It was. I had a seamless recovery, Carrie.
Fantastic.
I credit the skill of my surgeon, but I was a pretty compliant patient too. And I think I just had great fortune. I had great fortune in many respects for my recovery. Patients need to know the reality of any surgery.
Absolutely.
There are risks, there are complications. You can develop seromas, you can develop wound issues. But the thing of it is, I go back to my comment about being someone who has a high success rate and who engages in a shared decision-making conversation, uses AirAss protocol, all of the above. To me, even when you have complications, a good surgeon is going to see you through those, because I have talked to women across the country who have been to, PRMA and who have been to other top-notch surgeons across the country, and they develop wound issues, but they get fixed. They are okay, and their surgeons see them through it. It may take a little more time than what mine did. I had a seamless recovery, but they come out on the other side in great fashion because they had a great surgeon.
Yeah. I think it's so crucial that when you're, like Dr. C was mentioning earlier, when you're diagnosed, to really taking in all that information, having someone else help you take in all that information, taking notes, and going home and really sitting with that for a minute or so, days, weeks if you can, and really, really do your research, because you just don't know what you don't know. And more podcasts are out there like ours, more and more organizations like ours are out there to help you navigate that. And we know, but it's a federal mandate that you're supposed to have a breast care coordinator or a navigator assigned to you when diagnosed. I can't tell you how many people come through the doors of the Care Project here and have never heard of such a thing. And they're just told, well, this is what you're going to do. You're going to do da 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 da, which is why this new Breast Advocate app is amazing, right? And that whole, patient being involved.
I was going to say, this is a perfect time to throw that in.
Yeah, we need to talk about
throw that in now. It's
And
yep,
Terry, before we get
Let's
to the
talk
app,
about it.
Before we get to the app, tell me the website for your foundation and what exactly you do.
Yeah, so I named my foundation from the procedure I have. So it's Deep Sea Foundation, and it's DIEP with the letter C, which is the first initial of my last name, and then foundation.org. So deepseafoundation.org. But the evolution of my advocacy has led me to advocate for all options of reconstruction. That is, really what I call now, to me, it's an evolution of 4 options of reconstruction. Tissue reconstruction, which I had, and there's different forms of tissue reconstruction. You can take flap surgery from other parts of the body if you're not a candidate for deep. There's also implant reconstruction, which, even today, a majority of women are choosing that. The third option is a combination of both tissue and implant reconstruction. And now, again, the evolution of this advocate, when a when a plastic surgeon or a breast surgeon works with a breast cancer patient, the scaffold that they are working on is the chest wall. So women who choose not to have reconstruction, a type of reconstruction is reconstructing the chest wall using aesthetic flat closure.
Yep.
So that's a whole nother topic, but
that is another topic.
But I do want people to know that the foundation advocates and supports all options for reconstruction, provides a ton of resources. So
I love that.
On the podcast we can go into
for sure. I definitely want to do that, because as it sits for me in this very moment, and this could change, but right now how I'm feeling is, if I could safely go in and have all this removed and be flat, I wouldn't even care what the hell it looked like, because this is so cumbersome what I'm dealing with now. Because like I mentioned, 9 years before diagnosis, I had a reduction. So clearly I didn't want to be that big. Now I'm bigger now, and it's just a hot mess. And so I think that I talk about it all the time on my show. Breast surgeons, oncologists, your team, when you're first diagnosed, needs to give you all the options, including going flat and staying flat. So thank you for your foundation and for what you do. And we will definitely schedule another show to talk specifically about what your foundation does and go more in depth about all that. I know you got a hot date, so thank you for joining us. You can drop off. I'm going to keep talking to Dr. C for a minute. And we will.
You're welcome. And Carrie, I thank you very much. But I want to just say to you also that this advocacy does matter. It really does matter. And I think collaborative efforts between healthcare providers and patients in ways that we can all learn from each other and help each other find resources, access resources, healthcare, health literacy, education. Education is key. That's my background. So thank you for what you're doing, Carrie, and Dr. C. Always for your support, kind sir. And get after that Breast Advocate app. I'm going to drop off, go have my hot date.
Yeah, go have your hot date.
You guys continue your discussion.
Thank you, ma'am. You take care.
See you, Terry. Have fun.
I'll tell the old man you said hi.
Yeah.
For sure.
Dr. C, let's talk about the Breast Advocate app. What caused you to create it, and tell me exactly what it does?
So I created it because what I needed for my patients didn't exist. So I was getting very frustrated. So you go through different phases of your career, and I got to the point where, the operating, is that's the passion, but we have a great team, we have that down. You start to look at other aspects of providing top quality care, and then one aspect or one complaint that I kept getting over and over from patients was it was a variation of the same statement. If I had known then what I know now, fill in the gap, right?
How many times did I just say that?
Right. I hear it every day almost, every time I'm in the office. And then there's the frustration of, why didn't my surgeon tell me? Why didn't, all the same frustrations that we've touched on, today and more. So anyway, I thought, wouldn't it be nice if I had an app that just gave everyone the options, just all the options, right? Not just things that some surgeons do, but all the options. And then wouldn't it be great if it was presented in a way that wasn't like, the internet or like a book or, where you have to know what you're looking for, right? You go online and it's easy to find information about a mastectomy, but how do you know if that's what you really need or want, right? And so the information is all out there, but you don't know if it's a reputable source, and you don't actually know if what you're reading truly should be applying to you. What else should apply to you? So I thought, wouldn't it be great if we had a way of presenting all the information in an evidence-based way and then gave the patient the mechanism, the tools to help guide the conversation that they're having, to make sure that they have the conversation that they want to have. And so basically give patients the tools to share their preferences and what's important to them. Because, there are many people that have more than one option,
right?
Except that they're presented the information in a way that makes them feel that there's only one option. And that's sometimes the case, but I got to tell you, it's usually not the case. It's not reality. The reality of the situation is that if you were in a facility that offered everything, you would have more than one option.
Mm-hmm.
Right? And so there are certain aspects of care that aren't a good idea to avoid, right? So we talked about radiation, we talked about the issues of radiation, but people also have to understand, like I said, it's life before breast. When it comes to your life, there are people that need radiation because it's a benefit to their life, right? And we can talk about all the aggravation that comes with it, when the complications sometimes, and, but ultimately, sometimes people don't have a choice with certain aspects of their care. But equally, look at your situation. You may not have had a great option in terms of radiation. It would have been Russian roulette not to have it. For you to decline it, that wouldn't have been a good idea. But you had options after that. I mean, maybe the initial procedure. I mean, I don't know.
When I had my mastectomy, the one tumor that was much larger on the side, I mean, I was like scooped out like a melon baller, So the fact that I could have anything, like I knew it was dicey. And so I felt like I didn't have, I don't feel like I had this is chemo brain. My expectation wasn't crazy. I had no way. I didn't think I was going to look like Barbie by any stretch. I just wanted to be as symmetrical as possible and just be able to wear clothing and not be in pain. I already had 28 lymph nodes removed out of this arm.
Mm-hmm.
In addition to that, I had the radiation, which when I went back and saw my initial surgeon, he was pissed off because he's like, they didn't have to radiate you. I already took all your lymph nodes. But, that was a whole debate in the medical community between the radiation oncologist and the oncologist and then the surgeon. And he's like, now you're going to get lymphedema. And I was like, whatever, I'm alive. I really do live my life. Like I try to keep shit in perspective. Let's just say that I'm happy to be here. But as a single mom with little kids, I did what I had to do. And when they said to me, you are stage 3, I will never forget the day. Well, when I was coming out of anesthesia from my mastectomy and my surgeon walked in and I looked at him and I said, and he was the kindest, sweetest man, rest his soul. He's no longer here. I said to him, I forget his last name. I said, Dr. So-and-so, I said, there's my hero of the day. And I'll never forget what he said to me verbatim. He said, oh, honey, surgery isn't going to save your life. Chemo and radiation is going to have to do that. The horses are out of the barn. I said, what the hell does that mean? Because you don't know what you don't know. He's like, well, I looked in your armpit and I saw gross evidence of disease. Now, I'm a trained medical transcriptionist. I know what that means.
Mm-hmm.
I was like, okay. And our agreement was before surgery, if you go in there and you see that it's definitely in there, just go on and take them out.
Mm-hmm.
I said, treat me like you would your sister or your mother.
Mm-hmm.
And he did. Then I went on to have radiation. So now here I am with this range of motion, pain constantly, ton of scar tissue. And, but I'm grateful. Like I really live in a state of gratitude just for being here. And for most of the time, I don't really think about all this. I just deal with it. Right. But when I took those photos to send to you yesterday, I did it so haphazardly. But when I did that and I looked at them, I was like, oh, let me just keep it real. This is what I said. I am all kinds of fucked up. That's what I said. And I was like, holy crap. And I'm single, right? So it's like dating and all that. Oh my God, forget about it. But I'm just like, wow, I am so thankful on behalf of your patients who get amazing results because I know how important that is just functionally. Forget aesthetically, functionally. I can't wear a regular bra. I can't wear a mastectomy bra. I have to just wear sports bras or camisoles that compress and like it's a shit show under this top, What can you say to patients like me? Because I know I've had you on here for so long. What can you say to patients like me? Like at this point, I just stopped. I was like, yeah, I'm not. He's like, well, we're not done. We're going to go back in. And I'm like, I don't think I really want you to touch me. I really don't. I think he's doing his best, but he clearly is not as skilled as some others like you. So, what do you say to patients like me? Do we keep going and find another surgeon and hope our HMO will pay? I mean, I know there's laws in place now, but what's your thoughts?
You know, my thought is that you've got to, I mean, you've got soul searching to do.
Yeah.
I mean, because this isn't a one size fits all approach, right?
Right.
I mean, um, it's so personal. Everything about it is so personal. But what I will say is that the key to the best outcome that you could have, not just you, but anyone, is feeling that you're involved in the decision making. It's been shown.
Yeah.
Right? So when patients are involved in their decision making, they have better outcomes. The outcomes that they perceive are better. They feel better about stuff, whether they have a complication or not. They've been involved rather than after the fact. Why did I have this again? Oh, wait, what? I had another option? What?
Yeah.
Yes, you did, but now it's too late, you know. Right. So I think, and that was the biggest reason for Breast Advocate, right? It was there are so many options, and so few surgeons offer all of them.
Right.
The best thing I can do is make something that doesn't exist that fills that void. So it was funny, you know. I think, I mean, I'll never forget this. So it was a weekend. I was at my eldest plays tennis. I was at a tennis tournament, and phone rings, and it was someone who found me on LinkedIn, and he found the app on LinkedIn. And he says, look, here's he's a very, very well-known national breast surgeon. Let's just leave it at that.
Mm-hmm.
Why doesn't this exist? You know, it's amazing. And, you know, can I be part of your board and all this kind of stuff? I said, mate, you know, this sounds great. Thanks very much for your interest. So why don't you take it for a spin, download it, try it out. And then let's reconnect in a couple of days and tell me your thoughts. So he says, you know what, I'll do one better. I'm going to give it to one of my patients who's a really big time advocate. And, you know, she's done now with her treatment and blah, blah, blah. She'll love this. She's all over tech. So then he calls back and he was pissed off at me. What's wrong? He goes, you got to take this out of the app. You got to take this out of the app. You got to take this out of the app. I'm like, wait. Why? Tell me. I mean, I said, all feedback is great. It's the only way we get better. Why should I take this stuff out? He says, well, because my patient now is pissed off at me because I didn't tell her about these options.
That's great.
Okay, so what you're telling me then is the app works.
I was just going to say that. You're like, thanks, buddy, for the endorsement.
So I'm like, this is great. So no, I'm not taking it out, right?
Yeah.
So I guess this all feeds back to your question, right? The key to being happier is just being as comfortable as you can be in your decision making. So people are smart, women are smart, guys are smart, right? I mean, the benefit is people in your situation no longer have cancer, so you do have the time aspect on your side. You've got as long as you feel you need to make a decision. And now you've got resources out there, patient advocacy groups, the app, other apps. And when it comes to breast surgery specifically, there aren't many apps out there. Breast Advocate is pretty much the only one for surgical options. But you've got time, right, to do your research and get as comfortable as you can be and learn what's important to you to help guide the decision making. And that's gonna make you more bought in. And people who are more involved in their decision making also do better if they get a complication because they went in understanding. Right. And then I guarantee you, any physician that practices in a shared decision making way, I think in my experience is more likely to have a team that are going to be there for you because they've already shown you they value patient involvement. Right. So I think irrespective of the situation your listeners find themselves in, I'm a big believer in self-advocacy.
Absolutely. We talk about that all the time. People think it's just a catchphrase, you know, be your own best advocate, but that shit is real. And this app, this Breast Advocate app is so needed. And I'm going to be sharing this. I don't think it's on our resource. I'm going to I have volunteers here that run the care project. So I have a volunteer friend who does the website. So I'm going to definitely add it and Terry's organization to our resource page.
Thanks. That's awesome. It's
No,
free for patients. We keep it running through industry sponsors, so it's always going to be free for patients.
Yeah, that's awesome.
And, the patients also have to realize that they are, and a lot of physicians don't like it when I say this, and they have an issue with it when I say this, but it's the truth. Patients drive care. They have the power, especially in a fee-for-service environment like the US. If you want something, especially if you're in a position where you don't have an active cancer and you don't feel time crunch, the time pressure, and you don't have the emotion. But even if you do, as we've said, most people have a little bit more time than they think. You have the power as a patient to drive the conversation, and
it's so important to hear from you, a physician, because so many patients come in here and say, well, my doctor said this and they didn't mention anything else. And we'll ask, as survivors, we'll say, well, did he mention this or did she mention that? And they're like, no, they just said this. Well, did you ask?
No.
Well, no, because they don't know. Yeah. So I'm going to have this all over plastered inside the Care Project as well.
Or we can send you some postcards too if you want.
Perfect. Yeah, well, let's do that. Well, I will let you go. I thank you from the bottom of my heart. You're always a joy to speak with, and you're so approachable. I really appreciate you.
Oh, thanks. Let's do this again. It was fun.
Yeah, let's do it. I'll have you, maybe you could speak to my group one day.
Sure.
I'm doing that tomorrow. I have a nutritionist coming in. We have a whole wellness team. So we realize our tagline for the Care Project is never stop caring, because we realize that managing survivorship is often the hardest part. And for me, that's been the hardest part. When I was diagnosed, I just went, okay, what? Okay, what do we need to do? Let's go. And you put your head down and you plow through, but then you're sent home to go recover before you prepare for the next thing. And you feel like you're just abandoned. I always say you're like the baby bird in the nest, right? When you're in treatment, you've got this team of clinicians all around you, taking care of you and your friends and your family. Then you ring the bell and you're done with active treatment and everyone goes, oh, you're good now, right, Madrid? You good? You're back to normal? And it's like, fuck no, what just happened, right?
I know that is the whole now what, right? Now what do I do?
Yeah, and every headache, you think it's brain cancer, and every backache I thought was spinal cancer. And
the stuff you're doing is so crucial, right? I mean, we have a survivorship section in Breast Advocate, but that's never going to be the same as the in-person,
right?
Camaraderie.
Yeah.
From people who have walked in your shoes.
Absolutely.
So what you're doing, you, Terry, I mean, it's really, really so crucial. So thank you. Thank you.
Absolutely. All right, sir. Well, you go have a good weekend.
Cheers.
Free those kids' arguments and take care, sir. I'll talk to you soon.
Thank you for listening to Handle with Care, Breast Cancer and Beyond. Please let us know what you think of the show by leaving a rating and review. And don't forget to share it with a friend. For more information or to connect with Carrie, go to thecareprojectinc.org.